Let's begin with section 1 of our lecture topic, obstetric emergencies. And in this patient, we will talk about the sepsis and the collapse patient. The topic we will discuss in this section is mainly the collapse patient and the sepsis, but we will also talk besides the collapse patient and sepsis, what is the prevention of medical emergencies and how we manage these medical emergencies. And then we will also talk about the sepsis, what is sepsis and what's the management of sepsis. So obstetric emergencies. First, the thing we should know is what is considered an emergency. What is emergency? An emergency is a serious situation or occurrence that happens unexpectedly and demands immediate action. Emergency is not something that we know that this is going to happen. Emergency is serious situation that occurs suddenly, happens unexpectedly, and we should be ready for that emergency all the time. So we never know what time the emergency can come, so we should be ready to deal with that emergency at all the times to avoid the outcome of that emergency that can be very, very fatal also. So serious situation are the occurrence that happens unexpectedly and demand immediate action. That's the emergency. It's common. Obstetric emergencies are not uncommon, they are common. So in the obstetric units, in the obstetric wards, we should have the staff and the obstetricians that should be ready for dealing with these emergencies. So they are common. Maternal and fetal mortality and morbidity is high in cases of emergencies. 1 maternal death per minute worldwide. So you can see how high is the statistics of maternal mortality associated with this emergency. So there is 1 mother dying in the world every minute. So we should be very, very clear, ready to deal these emergencies. In UK, the estimation rate is 1 in 100 births. So 1 out of every 100 births needs admission in high dependency units during the obstetric emergencies, and 1 in 1,000 births they require admission in intensive care unit. So 1 in 100 requires special care. 1 in 1,000 are the patients who actually are admitted in the intensive care unit. A stepwise management approach is required to deal with these emergencies. Next is the prevention of obstetric emergencies. We sometimes cannot prevent these emergencies, but it's very important that we should know that the certain factors are present or certain conditions are present that might lead to obstetric emergency, and we should be alert when we are dealing with that patient. So prevention of obstetric emergencies, difficult to prevent, as I mentioned. Sometimes things happen and we have no control on them. We cannot stop them from from occurring them. But the thing we can do is to keep in mind that at some point during the pregnancy, this emergency can occur and we should be ready to deal with that emergency. So prevention is difficult, but the approaches we should have is recognition of warning signs. We should recognize the excuse me, we should recognize the warning signs. Warning signs can be like high blood pressures. If patient is coming with high blood pressures on antenatal visit, we should be alert that patient can have preeclampsia or develop eclampsia later on, and we should be ready to deal with that emergency, and we should start precautions to prevent that emergency. So recognition of warning signs is important. Next, the reduced risk factors. Risk factors that can lead to that complications or emergencies, we should try to reduce those risk factors. That's again very, very important approach for the prevention of emergencies. And then support in anticipation, support in what can occur or what can happen. We should support or work in that. So all these are very, very important approaches for the prevention of obstetric emergencies. Next, the management. Management is important. We should prepare the patient and prevent the bad outcome of the pregnancy. So prepare and prevent, try to prevent, try your best to prevent. So prepare and prevent is one part of the management of the patient. Call for help. If you don't know how to manage that emergency, the first thing after you prepare and try to do some help to the patient, the other very important thing is call for help. Call for special help. Call for the ambulance to transport the patient to the hospital, to the good place where the good management can be given. So call for help is important. Talk to patient. If patient is conscious, patient can respond. Talk to the patient. Tell them that what's going on and what you want to do. What's your plan for the patient? Because otherwise they will be really very anxious and nervous. What's going on? So talk to the patient. Turn into left lateral tilt. Left lateral position is very, very important. Turn the patient to the left lateral side. So the circulation should be improved. The pressure of the gravid uterus or the pregnant uterus on the blood vessels should be relieved. So turn the patient to the left lateral position to avoid any aspirations also. Assess the airway, assess if the airway is functioning or open, assess for the breathing and circulation, and administer high flow oxygen if open airway is open and the patient is breathing. Administer high flow oxygen. So that's the assessment. First you assess and then start giving the oxygen. Insert 2 large bore cannula into the blood vessel. So later on, if the patient goes in shock or if the patient collapses, it's very hard to find the veins. So the as long if the circulation is good and patient is not collapsed, then important thing is put 2 large bore cannula into the vein. So later on, it's helpful for any fluid infusion. Immediately commence chest compression at the rate of 100 beats per minute. Consider and treat cause if there is no breathing and poor circulation. Provide chest compression to ventilation breath at the ratio of 30 to 2. So chest compression, 30 compressions, and then 2 breaths. That's the basic CPR, cardiopulmonary resuscitation. Lot of people who are in the hospital environment and the personnel, they should know the basic CPR and they should begin it right away if the patient needs it. So that's the initial management of the patient who comes with the obstetric emergency. Initial management, identify problem. The identification of the problem is important. What is causing the obstetric emergency? Cause of that is important to find out, so the management should process in the right direction. Airway with cervical spine control. Breathing with ventilation, breath sounds and chest movements, high flow oxygen. Circulation with hemorrhage control, reduce aortocaval compression, start CPR. Disability, if there is any neurological disability, look for any status, neurological status, AVPU score, Glasgow coma score. If less than 8, patient needs intubation. So these are all the neurological examinations. Then exposure depends on the environment where the patient is at the moment. Examination, urinary catheter and nasogastric tube should be inserted depending on again where the patient is present. If the patient reach the right place in the environment where these type of cares can be provided, then patient should be catheterized and the nasogastric tube should be inserted. So all these are the initial management steps depending on again what's the cause of the emergency and at what stage the emergency is. Resuscitation, differential diagnosis, assess the fetal well-being and viability, look for what can be different causes that's causing this problem. And then next important step is the assessment of fetal well-being, if the fetus is fine or not. Review the notes, review the patient history, review what might be the cause of this emergency. Definitive care and management should begin after the initial evaluation, initial assessment. Once the patient is in the stable condition, then all this can happen. Assessment of the fetal well-being, review the notes, and then find out what can be done for the definite and final management of the patient. Encounter problems might be more aspirations of gastric contents, higher metabolic oxygen, lower functional residue capacity, weight gain, and larger breast. Sepsis. Next, what's the sepsis? We talked about the management of the obstetric emergency, how we can prevent it, what are the different risk factors we should consider while managing it. Next, the sepsis. The risk factors for the sepsis. Sepsis is when the infections reach the bloodstream in the body, and then through that blood it goes to different parts of the body. Then it can lead to sepsis, low blood pressure, shock, collapse patients. All these occur as a result of the sepsis. So the risk factors for the sepsis is the rupture of the membrane and then causing infection and then the spread of that infection. So ruptured membrane, I see immunocompromised patients and the patients who are on the immunosuppressants, they can be also lead to sepsis. If patient is obese and diabetic, they are more prone to sepsis. Anemia, urinary tract infection, amniocentesis also lead to sepsis. Streptococcal infection, and then vaginal discharge. So risk factors for the development of the sepsis is all these factors: ruptured membranes, different infections, urinary tract infections, immunocompromised patient, and the patient who is on immunosuppressant drugs. What are the warning signs of sepsis? How the patient will be alert, or the obstetrician will be alert that the patient might have sepsis? Pyrexia, hypothermia. So patient might will present with pyrexia or fever or hyperthermia or increased temperature, or the patient might have hypothermia, or they are very cold, low temperature because they have low blood pressure, they have sepsis, hypovolemia. Tachycardia, heartbeat is very fast. Tachycardia is another sign of sepsis. Hypotension and oliguria. Blood pressure is very low and there is oliguria, no urinary output, is another sign of sepsis. Increased breathing rate, reduced consciousness if like tachycardia, which is increased heart rate, increased breathing rate is tachypnea, or fast breathing is present. Level of consciousness of the patient is affected or low, and there is rigor and rash. So all these are the different signs which are associated with the sepsis. Management of the sepsis is antibiotics are used, but it's very important that we should get the culture, blood culture, before starting antibiotics, because it's important that we should know the exact causative agent, so exact treatment should be started. So obtain the blood culture before starting antibiotics. Within 1 hour of sepsis, administer antibiotics. Then measure serum lactate levels. Hypotension, serum lactate more than 4 millimole per liter, or total amount of 20 ml per kilogram is serious. No response, then give vasopressors to the patient. Persistent hypotension and central venous pressure is more than 8 millimeter mercury, then we should central venous oxygen saturation more than 70%, mixed venous oxygen saturation more than 65%, involve microbiologist if no response to antibiotics. So this is the management of the patient. We need to have good oxygen saturation and good mixed venous oxygen saturation, and if there is no response of the patient to the antibiotic, to the vasopressors, to the oxygen therapy, then the microbiologist should be consulted to treat and to start the right antibiotics. So this is the management of the sepsis. Antibiotic usage, what are the different antibiotics that can be used in the sepsis? We have first usually before the culture, if we start the antibiotic therapy, we should guide by the risk factors. We should know what were the risk factors that can lead to this sepsis, and then that's the guideline for the usage of antibiotic therapy. The commonly used antibiotics, we can use co-amoxiclav, which is for gram-positive and anaerobe cover. This gives gram-positive and anaerobe cover for the patient. Do not cover methicillin-resistant Staphylococcus aureus and Pseudomonas. Then we can use metronidazole, which is for anaerobe cover. Clindamycin is for streptococci and staphylococci, clindamycin. Gentamicin is for gram-negative cover against coliform and Pseudomonas. So all these are the different antibiotics that can be used against different microorganisms, that can be effective against different microorganisms, but the exact causative agent only we can find out when we do the culture and then start the antibiotic to cure the patient. So that was all about section 1. Thank you for watching sqadia.com.